Hello and welcome to Health Matters on Channels Television. Thank you for staying with us. I am Mary Alale Yusuf. Pediatric rheumatic diseases, PRDs for short, is an umbrella term that includes the range of musculoskeletal, arthritic, and connective tissue disorders which start in childhood. The term musculoskeletal has to do with muscles, bones, tendons, and the rest of the skeletal system, while connective tissue supports, protects, and gives structure to the organs in the body. It also stores fat and helps move nutrients, among other things. There isn't a lot of data about pediatric rheumatic diseases, but studies suggest that the prevalence of rheumatic diseases in the general population ranges from 9.8% to 33.2%, and it has been estimated that 15 to 45% of primary care physician consultations are for musculoskeletal problems. My guest is a pediatric rheumatologist, the first in Nigeria, a consultant pediatrician. Dr. Ayodele Faleye works at the Lagos State University Teaching Hospital. You're welcome to the show.
Thank you very much.
Can you give a simple definition of pediatric rheumatic disease?
Okay.
Just a very simple one.
Simple definition. Okay. These are lifelong, because you said it should be simple. They are lifelong immune-mediated musculoskeletal and connective tissue disorders in children generally. I mean individuals less than 18 years.
Okay.
So what do I mean by immune-mediated? They are autoimmune. That means
it's
that
like the body fighting itself.
Yes, the body is supposed to, the immune system protects the body from germs. That's why we are not sick every time. But sometimes the immune system itself now faces some of the body structures like the musculoskeletal system and vital organs in the body. That is autoimmune. And the major system most affected is the musculoskeletal system. So that means that we are musculoskeletal physicians, and we see individuals less than 18 years. So that's what is meant by pediatric and rheumatic diseases.
Okay, so children effectively are up to 17 years then?
Yes, by 18 they have to transit to the adult clinic.
So I believe that those statistics include the adults, the statistics I gave, but can you give us an idea of how common these PRDs are? How often do they occur? Okay. If not all over the world, in Nigeria?
Okay. Let me start from home. What is happening in Nigeria? We do not have data. But we have, it's been reported in a tertiary center in Lagos, to be precise, last 57 cases that were seen over 5 years. That is what we have presented. Then we have other case reports from other centers in Nigeria. Now, with my own practice in Lagos for the past 2 years, between February 2022 and now, we have had more than 100 cases of rheumatic diseases.
Between February 2022 and now?
Yes.
But that's a much higher percentage, it
yes,
seems.
Compared, yes, probably because we now have a specialist, and within the hospital there is now high index of suspicion for these diseases compared to what we had in the past. So, and you know, in the US, it's been reported in a study that they diagnosed 294,000 children yearly with pediatric rheumatic diseases between 2001 and 2004. But what is happening in Nigeria, we don't know. Like now, I am just giving you figures about Lagos. I don't know what is happening in other 35 states in Nigeria.
And then how about those who don't even know their children have the problem? So there's probably a lot of under-reporting in this matter.
Before we even talk about reporting, under-recognition, under-diagnosis. You know, you have to diagnose before you start reporting. So there is under-diagnosing and under-recognition of these diseases. Not even among the, not even in the society alone, even among healthcare workers. Because pediatric rheumatic diseases are yet, or let me say pediatric rheumatology is yet to be part of medical school curriculum. So that means we were not taught in the medical school. But in the course of practice, we found out that these children actually exist here in Nigeria. And From there, we started seeing many of them in the clinic and on the ward. So we still have a lot to do when it comes to data. We do not have.
Maybe one of the problems is the word rheumatic. You know, whenever I hear the word rheumatic, I'm like, catarrh, you know, rheum. Is there any connection?
It's not.
There you go.
Yes. You would think more of the joints.
More of the joints,
yes.
Right? Okay. Can you give us examples of the most common PRDs in Nigeria?
Well, we have the most common, reported by most pediatric rheumatologists in the world, is juvenile idiopathic arthritis.
Okay, but arthritis is a recognizable word.
Yes, juvenile idiopathic arthritis, which can be diagnosed in a child who is less than 16 years, who has at least arthritis of one or more joints that has been ongoing for 6 weeks after you must have excluded common causes of arthritis, common causes of joint swelling. You know, it can be of infectious origin.
But yes, that will not last. When you say idiopathic, it means you don't even know the cause, right?
No, we do not know the cause. So that is the most common. But the experience here in Lagos is different. Here in Lagos, I see more of lupus. Maybe juvenile idiopathic arthritis is common. Probably the parents are buying pain relievers for their children at home and they are yet to present in the hospital. But you know, when it comes to lupus, that is a connective tissue disorder. And they will always have symptoms that are quite disturbing to the parents that will make them to present the patient on time to the hospital. But for joint pain, the parent may feel, oh, just go and take paracetamol. She will overcome it as she grows up, you know, until complications set in. Yes.
Now, I know it will be useless to ask you what is the cause of lupus. I know that is just so amorphous. People don't really know. But do some PRDs have causes?
The cause is unknown. We do not know the cause, but it's been reported and it's been seen to run in some families. Okay. Where maybe a mother will have one of the autoimmune diseases, the child may have another one, or they may have the same autoimmune disease. Then also it's been said that exposure to some viral infection can predispose one to rheumatic diseases. But that is in a person that is genetically predisposed. We all have viral infections, but not everybody has come down with autoimmune disease. So some viral infections too have been attributed. And being a female, you know,
they have it more.
Yes, females have it more. In the ratio 5 to 1, 5 girls to 1 boy. So this is the reason that has been, you know, documented that the female hormone called estrogen,
there we go,
is immunogenic. Then also, you know, we have what we call genetic sex. Men or boys, they have XY. Ladies have XS. That second X in a female too is quite immunogenic and can overdrive the immune system. And that can tip the individual to what we call the autoimmune diseases. And, you know, pediatric rheumatic disease is one of them.
Can you describe how a PRD would affect a child? What does the child look like when a PRD is active in the body? What are the signs that one sees?
Thank you for your question. There is a symptom that crosses across almost all the PRDs, and that is arthritis. What do I mean by arthritis? Arthritis means that a joint is swollen, it is painful, it is red, and the child is unable to use it. There's loss of function.
Wow.
It is different from pain, which is called arthralgia. So many people make that mistake. So arthritis cuts across. Other symptoms that they could present with hair loss, like in lupus.
What loss?
Hair loss. A child that did not visit the barbing salon, but lost all the hair on the scalp. Oh. While combing the hair in the morning, the child will notice that there are so many hair strands on the floor.
Is that not common with cancer rather than?
It is also seen in cancer. We call it alopecia, maybe from the effect of their drugs. But in pediatric rheumatic diseases, we can see that some of our patients, they have what we call alopecia, which could be total or partial. So especially in lupus, you find out that most of them, they have lost their hair without barbing it. So that is significant in them. Then also they can have rash, any type of rash. may carry, you know, a lot of meaning, or may make a lot of meaning to a pediatric rheumatologist. Any type, whether it contains fluid, whether it's flat, whether it's raised. I don't just want to be using our terms now.
Yes.
Any kind of rash may raise high index of suspicion for all these diseases. Then sores in the mouth, wound in the mouth or in the genitals, red eye, gritty sensation in the eye, as if somebody poured sand in the eye, and the child is always itching the eye, because sometimes...
You know what's passing through my mind now?
What is it?
Different diseases that are not PRD.
Yes.
Conjunctivitis, this venereal disease.
Yes.
You know, these symptoms are so generalized,
yes,
so to speak. But they are generalized for many things.
Yes. So, and that is why it's very difficult to diagnose pediatric rheumatic diseases. Most symptoms and signs that a doctor will see when they present could mimic most common tropical pediatric diseases.
Okay.
And that is why sometimes some of our patients will be with the hematologist. They will be thinking it's sickle cell, run genotype almost all the time. They could think it is malaria, keep treating malaria for so long. They could think this is TB. Some children are being treated for presumptive TB. Well, it is not. And that is why we have to have... Is that
because they are coughing?
Yes, because they could have cough, they could have chest pain. And there's something that is also very, very peculiar to these patients. Extreme fatigue, extreme tiredness.
Ah, okay.
Not the tiredness of teenagers. You know, they like to escape house chores, not those ones. But a child who is not interested in the environment. Always sleeping, not interested at all in anything, you know.
When we say a child, how young can one detect these signs?
Well, it takes being very sensitive.
You really have to be.
Yes.
Because if we say, when you notice that the child cannot use the fingers, maybe due to arthritis, the child has to be 3 years old or 4 years old, and a lot of time would have passed. Can it be discovered before that time?
It's difficult. There must be signs and there must be symptoms. Then I must also say that you are saying 3-year-old. We have diagnosed it in children less than 1 year.
Wow.
Even as early as 3 months of life. So that means that the parents must be very sensitive. Don't overlook anything on your child. Present the child to the pediatrician for proper evaluation. It could be anything. That is to tell you that there are so many symptoms of PRDs that overlaps with what we know commonly, especially because we are in the tropics.
Yes.
Yeah, you may think this is sepsis, infection. And what I want to say at this point is this. If there is any diagnostic dilemma, I think the child should be referred to a rheumatologist.
So if they are ping-ponging the child up and down, maybe it's this, maybe it's that, maybe it's the other, then we should think rheumatologist.
Yes.
But how confident can one be that if the child has pediatric neurology, a doctor will recognize it and refer?
Yes.
And then how many of you do we even have in this country?
The major issue is late presentation here. These patients do present to us late because most times the signs and the symptoms will have been missed.
Okay.
Yes, because though there are telltale signs of some of these diseases, like I've seen a butterfly rash. One minute there's, around the cheeks, this is lupus, Most doctors, because it is in most medical textbooks, so you want to refer that one. But unfortunately, not all our patients with lupus presented with malar rash.
Butterfly rash.
Yes, what we call butterfly rash or malar rash. Most of them did not present with that. So it takes high index of salt. And that is why I'm saying that even if a patient is with you with a particular symptoms, patient is not getting better, you need to refer to the... Like we have had a patient from the neurology unit before with recurrent seizures. And she was managed for seizure disorder. She was on anticonvulsant for 9 months, but she had no improvement until she developed joint swellings. That was when the neurologist thought of rheumatology, and he was able to refer to us. After investigating this girl, we diagnosed her with lupus.
Wow.
So that is to tell you that...
How could he have known?
He wouldn't have known. And that is why we are raising awareness. once you are finding it difficult, once you cannot control that symptoms, once the patient keeps coming back, once the patient keeps having fatigue, once you are not winning, think about rheumatology. Once you've given so many antibiotics, you keep treating malaria and over, you keep giving treatment for tuberculosis and the patient is not getting better, think about rheumatology. Then there is another symptom that I did not mention, what we call constitutional symptoms, which is common in them. We have fever, fatigue, loss of appetite, and weight loss. Anybody with these that, that has been of long duration can be referred to a rheumatologist.
Okay, so let's take a short break at this time. We'll take a short break and be back right after this. You don't want to miss this. Stay with us. Welcome back. You're watching Health Matters on Channels Television, and we're discussing pediatric rheumatic diseases, PRDs for short, with Dr. Ayodele Faleye. If you want to ask questions on this issue, something is troubling your mind, or you want to make a contribution, you can call 0808-054-2233. You can send a message on X at CTV_Mary A, or send me email to moalale@channelstv.com. I presume there's a way to manage these PRDs that will make life bearable for the children.
Yes. Yes. We have medications, but this has to do with how the child has presented to us. Okay. Sometimes they present acutely ill, so multidisciplinary approach to care will be very important then. Then after which we have our medications that we call disease-modifying anti-rheumatic drugs. We also have what we call steroids. Then we also have supportive treatment for these children.
And they use these things all their lives?
Yes, but for juvenile idiopathic arthritis, the child may outgrow the symptoms.
Ah, wow.
Yes, there are some that may outgrow the symptoms and the signs, but those that do not outgrow it, they will transit to the adult side. Who outgrows the symptoms? We don't know. You study, nobody can predict the disease course. COURLC. You don't know how it's going to go. Yes, you can't predict that but just make sure you try your best. Commence the medication. Some will actually outgrow the diseases and outgrow the medications.
For children with this arthritis, will they be able to go to school? Will they be able to write with their fingers? Because I'm thinking of, difficulty with bending the finger joints.
Yes. Yes, they are able to go if they present early.
Okay.
That can be reversible. But once fixed flexion deformity, once it sets in, that may be irreversible with our medications. And that means that the child is presenting to us with deformities, which has to be managed throughout life. And, we've seen children that presented with us on wheelchair before. Before they got diagnosis, they were already totally disabled.
Let's quickly take this call. Let me pause you for a moment and take this call from Oluwaseun from Lagos Island. Hello, Oluwaseun.
Yes, good afternoon.
Good afternoon. What's your question?
Yes, my question is very straightforward. Is there no particular test? Is there no particular test that can be run to show that this child has this disease?
Very much, Oluwaseun. Brilliant question. He's asking if there's no particular test to at least show that this is the problem with the child. Yes. He has a PRD.
Yes. We have what we call ancillary investigations, like, the common full blood count, erythrocyte sedimentation rate, C-reactive protein that we do for these children. And we have the parameters we look out for that will make us to be suspicious of these diseases. And we have what we call the autoantibodies, our serology, that we do, that takes some time before it is ready. We do send the blood to the lab, but it takes about 14 working days before we have that. So when we do this serology, this can help us to detect the abnormal antibodies in the blood that is actually causing the issue. And the type of antibody that is detected can even guide us as to what type of pediatric rheumatic diseases.
Good.
The types.
That's more targeted.
Yes.
So if doctors and patients, people suffering from it, can get to you faster,
yes,
then the result will be better.
Yes.
Because you can actually tell definitively that
yes,
there's a problem in
yes,
a PRD.
Yes.
Okay.
You see, that is why we are raising awareness. Monday is World Young Rheumatic Disease Day, March 18 every year. And this is what we are trying to say. Importance of early presentation, early diagnosis in the hospital. Importance of early diagnosis and prompt treatment is our focus for this year. Okay. We don't want to be missing it again.
Let me just pause you there and get another call. We're getting a call from James in Olodia Papa. Hello. Are you there, James?
Hello?
Yeah. What's your question?
Yeah, what about someone that is having a swollen leg? What is the outcome to the swollen leg?
Swollen leg, do you mean the whole leg or the joints, the ankle, the knee?
The two legs.
Swollen legs.
Okay.
Yeah.
So we deal
Thank
with...
you, James.
Thank you. We deal with swollen joints. The leg is different from joints. When you talk about joints in the leg, you talk about maybe the hips, the knees, the ankles, then the toes. Then even before you get to the toes, there are so many joints in the foot. So many small joints in the foot, and that is what we deal with. We don't deal with, we talk about musculo, that is not arthritis. Swollen leg is not arthritis. There may be so many other causes.
It could be diabetes.
Yes, it could even be cardiac failure.
Oh, wow.
Yes, if it is in big children or in adults, though not so common in small children. So swollen legs is not arthritis. What we are talking about is swollen joints, a particular joint that is swollen. That is what we try as much as possible to establish.
So let me quickly ask you, what challenges do you have with management? Let's quickly take Rose from Warri before we do that. Hello, Rose. Rose, are you there? All right, then. So what are the challenges you face? I think we lost Rose.
Yes, the challenges is, one, I've talked about that, that's late presentation. It's a big challenge because we don't want children that will come in and need ICU care or dialysis, 3 times a week. Everybody's running helter-skelter when we know that this could have been prevented by presenting early, yes, or on a wheelchair. You are now trying to rehabilitate the child. So a major challenge is late presentation. And another one is the fact that our investigations are very expensive. They are very expensive, and it takes a long time for us to retrieve the results. Sometimes when we have children presenting with signs and symptoms that are not clear, before we retrieve the results, we have lost the patient.
Wow.
So we need
That means they really came late.
They really came late, and at the same time, the investigation results were not retrieved on time. You have sent the blood, but you have to wait for 10 working days.
When you say sent the blood, you're talking about to where?
There are some laboratories, even within our hospital and outside, that that we send the blood to, and they get it analyzed. But we do not have machine that analyze autoantibodies that I know in Nigeria. Okay. What they do is that they send all these blood samples to South Africa or Germany, where the blood is being analyzed. Then they now send the result back to Nigeria. It takes a lot of time before we have that. So sometimes the patient presenting with something that is not straightforward, you have to see that result before you can start your treatment. And in the course of waiting, we may lose the patient. So that is another challenge. Then the cost of medications, very high, especially with the crisis with foreign exchange. Okay. The cost of medications now very high.
Okay, so first thing, report early. Yes. Second thing, we need the resources for investigation.
Yes.
I'm going to have to stop it here because we've run out of time, but this has been so interesting. And I'm sure a lot of people they're having new thoughts about a few things they're seeing. Yeah. Thank you so much for coming to the show.
Thank you.
Thank you for being with us. Thank you for your calls, James, Oluwaseun, and Rose. Have a wonderful day. Everybody else who's been watching, I am Mary Alale Yusuf.